Well, my career is really neuro-oncology. So I started doing research in neuro-oncology at the National Institutes of Health in the mid-60s, late 60s, and then continued and started my professional career at the University of California, San Francisco, doing pharmacologic research on anti-cancer drugs, and eventually treating patients on the neuro-oncology service. There was no field of neuro-oncology, and there's an argument whether I was the first one to coin the term or not, but we really were a brain tumor directed group, and it was basically dealing with brain tumor chemotherapy. So there was the radiation therapists and the surgeons, but the effort initially with the drugs was through a brain tumor chemotherapy group, or brain tumor service as we called it in UCSF. I think in the past decade there's been developed better treatments for tumors outside the nervous system. So you're talking now about metastatic tumors in the nervous system, etc. And the other thing is that we have better control over radiation therapy. We also have stereotactic radiosurgery, which allows more controlled, high-dose, either one-day or 2 or 3 day treatments that can be repeated, that have less toxicity to the brain. So those are really, really important. And people are starting to understand there's a genetic difference between one kind of breast cancer and another, between one tumor that gets to the nervous system and another that doesn't. So I think there are good options that are coming forward to help these patients. I think that I'm hopeful that this approach will bear fruit in the years to come. So this is part of the aspect of what people are calling personalized medicine, okay? So at the first level, you know why the tumor grew. At the second level, you know how to treat that specific type of tumor. So this is the goal, but this is not the reality today. Dr. Babustik are trying approaches, and they're basing these approaches on genetic patterns, on molecular markers. The goal being to be able to control the tumor. Sometimes it's going to work, sometimes it's not going to work. But the effort is to eventually get to that point. Private or philanthropic dollars, private foundation money, has been key in every new development. Because when you go to the NIH to ask for money, you have to have some experiments proving or strongly inferring that your approach and your hypothesis is correct. Well, you don't get that out of thin air. You have to create that. So most of the programs that I've been affiliated with and have been successful had as part of their nidus private dollars. And I think that to a great extent, much of the great success that our country has had in medical research. But in the laboratory, you can get more benefit, more leverage for your money, okay? So I would say that philanthropic dollars help that. They also help in studies improving quality of life. And those things are very important to patients today, and they're very important to patients tomorrow. And they're also extraordinarily important to the people who treat those patients, because that support helps them stay on this path I talk about, I believe in, where you're going to try to make therapy better. But you know that you might fail in doing that. But if you and everybody else keeps going in that path, somehow together you're going to get there. Their skill level, their perseverance, They didn't give up. And the other thing is they were a very moral, uplifting group. And so it was very important as a young person to reinforce good behavior and the ability to achieve goals and realize that when you try to achieve something and you try to reach success, you may not be able to do some other things. You may not be able to share in other experiences. But at the end of the day, it's worth it. And everybody works in the same, for the same purpose, to make it better for the patient. Some work in the laboratory, some work in the clinic, but the goal is to make it better for the patient.